besides the Jeremy's previous experience in working with the institution and the fact that we have a high community in it, you look at Rwanda, there's a fair amount of experience in Rwanda in using openness. Just think of the two new Jeremy recruits, they've been through the openness program, very specifically in training them to develop modules for OpenRS. Elvin Jonas team as well, he has a fair amount of very good quality developers producing great work in openness. So I think at a high level, if you were to choose OpenRS to play the role of the shared housing, that makes a lot of sense because we get a lot of that added benefit for free guys. So this is the sort of high level, same terms that we use to evaluate the registries and technology services. We start with a high level description of OpenRS. So I'm not really going to go through that because most people here are familiar with the system. And then, generally, if you go through each of these requirements and add each other evaluation against OpenRS, OpenRS puts the requirements of the SHR very well, I think, overall. There were just a few points that I would want to talk about that I thought it would be good if we could discuss that as well. So if you pause there and if anybody has any comments or suggestions, then they push it.
Again, the standard question is, what are the alternatives?
And that's a really good question. I think we only started looking at the shared housing very recently. And so at this point, the only direction we've done is against OpenRS.
Did you consider the hashtags at all?
No.
I think one of the challenges we're trying to mitigate against it is the amount of new capacity support that needs to be brought in. With the ministry having a very vested interest in OpenMRS, it does play us a long way along the ways of asking the question, why not? And to echo what Derek said yesterday, at this stage of the whole approach we're doing is not having to get it perfect, just making sure we don't make the wrong choice. And with OpenMRS being as flexible as it is, and while we're going to run through it now, it's just to evaluate how right or how far what would be at this stage, and open up some ideas and other systems if we do need to evaluate other solutions that we're finding. But to looking around for something that's going to provide us functionality that is open and easy to evaluate with the expertise that Rwanda has, I think it will be quite challenging. And the time constraints we have, we may be very limited in terms of getting that on the ground. But I'm going to hand over to Renee to continue through some of this. And these are some of the thoughts we are looking at as a team.
Okay, and so as we went through these requirements and started evaluating OpenRS, one of the things that, so I'm going to basically list through some of the items that sort of stood out in that. The first one was the security requirements on different data points. So maybe I should actually list to describe particularly what the requirements were.
Sure. So with a shared health record, the idea was that not everybody should get all the data that's in it. There had to be some kind of role-based security by a physician versus a community health worker, etc. The role-based security didn't matter so much. So not when we are only talking about messages that go back and forth, assuming that security is managed on the system that's sending the messages. But if we are going to have these OpenMRS as a web view to it, or sort of shared health record to have a web view or some other way, we need to be able to restrict access to specific people and show different data based on what your role is. A physician would have different data than, say, a community health worker versus a registration worker. And there was an issue with no role-based security. Second part of that was that, and maybe I stop there, but there's a use case that might be highly relevant.
Can I just comment that if we're talking about OpenMRS as the SHR, then its client is the HIE, which will then respond back. So there's another opportunity. And that is a trusted conversation between OpenMRS and the HIE. We're better served by putting whatever the insecurities are in the HIE anyway. So I'm not sure that's something that has to be done for the whole of the cycle. But I'm not sure that conversation between the HIE and OpenMRS is what we need to bring it all this.
So there's a different set of issues or configuration, and it's simply system-to-system messaging between trusted systems. The real question is, do we want an outside view of the shared health record, a web-based view, for example, that does not go through the interoperability there? Yeah, so the use case for that we had discussed earlier when we had a different solution is what we're going to do in the hospital. So these patients come in, which is really the predominant clinical benefit that we're going to get from this is that, in the health center, a certain amount of information is collected about them, but then if they want to go into the hospital, that information you can see it. So the hospital has to have access to the shared health record in some form. Originally, with our previous solution, there was a web viewer, which we had talked about doing. So we just needed to have the discussion here when it fits with the shared health record. What are we going to do in the hospital? Should the hospital run an instance of OpenMRS to manage that security, so all of the requests go through the interoperability layer, and how much does that add to the scope, et cetera, et cetera. So I'm just going to pause there and let people comment.
I have a question. Does adding this viewer support the use case? Is the use case whole without the viewer? I'm just asking a scope question.
I can't see any, how would the hospital see anything about the patient's record?
Meaning,
Well, it has to either have a viewer or it has to have an instance of OpenMRS running in the hospital,
right.
or another system running in the hospital that also connects to the interoperability.
So what you're saying is, are you asking the question, which way should hospitals view the data? Through OpenMRS query or through simply web view?
Yes.
Isn't that just a matter of detail? Either you query and load it into some sort of document or common form in OpenMRS, or you can, within OpenMRS, you're creating modules essentially on the web page, which
The question is around security. We have no security at OpenMRS is a video request. I'll tell you everything about them. I'm not checking anything about the security.
So are you asking which approach better supports security?
No, the requirement was for security, and in order to determine whether this is valid, between trusted systems, the shared health record does not need to maintain its own role-based security. If you're going to allow people to access it directly, it does have to have some notion that I need to approve making that request, because there's no trusted system on the other side.
Yes, I assure that at the hospital there won't be, there is no system at all. That assumption. There is no point of care system.
Yeah, or there's another system, OpenMRS or nothing. Yeah, one of those.
And if it's OpenMRS, why not go through the capability and get the shared circle?
Because we just need to make a decision that it should be OpenMRS. Then that's fine. I don't mind my support.
Yeah, I would say,
We've never discussed that formally as a group.
yeah, I would say, given that we've evaluated one system, OpenMRS, that's our choice unless we want to stop the project, which we don't. I agree with you that having role-based access is an important function, so we should explore with the OpenMRS team the possibility of getting that added. And I also thought that part of our use case, given that the clients in question do go to hospitals, that would include a viewer in the hospital. So if we're going to do that, and if we don't have role-based access built into the system, we're going to have to figure out some other way of securing access to that system. Either that or we don't implement that part of our solution. And I see everyone say, sometimes we do seconds.
The question is Gilbert. The rollout part in Namaka is in the hospital.
Really hard by that if they're really right now. So I don't know how that migration is affecting.
I know. Anyway, this is a decision that you've taken to use our numerals across the healthcare facilities. So we'll have to find a way to transition to this numerals. That would mean, it's a decision that you've taken, so we'll have to be. The minister has to do that. But I don't know, it doesn't seem like anybody knows when that's going to happen. To replace the system that they have, of course, you have to give them something that is functional at the hospital level.
And is that the ministry scope, or is that scope of this project?
I think it's scope. Because the other ones are really about the race.
The takeaway that they have, at least got to replace those functionalities and those finance and those things there.
Sorry?
If you take away the system they have right now, you at minimum have to replace that functionality. That includes finance and others.
Of course.
Yeah.
Of course. Yeah, that's why I asked that question. About how we, because we have a hospital level kind of environment, so it's about how really easy to be deployed vis-a-vis the timeline that you have for this project.
Right. So that's the question is, how could it be deployed? Is there some, and I think this is a project, if the decision is that it will be open MRS, and then it'll be used in the same way as the clinic, meaning that it will be role-based security and it will be a trusted system, which I understand is what the decision is, which is great. It becomes a timeline issue when the hospital can go live, and if we can, and from a project management perspective, stage that in, they might need to just use it internally initially as the rest of the system gets replaced or something like that.
However, I think just to make the point clear, we cannot expect all point of care systems to be optimized in the future. I mean, for this part of the first phase of project, of course, yes. But in the future, we expect, we have different hospitals which have multiple complex systems, and the vision is that those systems should be able to also carry out the shared health record. Okay.
And so the issue of, back to Wayne, the issue then of security, so on the shared health record doesn't matter because there will be nobody accessing the shared health record direct, only through the interoperability layer and another trusted system that's setting security. Everybody agree with that? So we come up with something.
Yes, in future, it's going to be this case where one would want to see summary of patients without necessarily having a point of care system. They say, for example, if you want to discuss about the case with a specialist who is not sitting in the facility with a point of care system, if that would be a possibility that one team should confine the shared report through the certain user interface, other than waiting point of care. I mean, I'm not saying again this should be part of the scope of this phase, but that kind of security should be built in. I guess there will be an institution that will be that.
I'm going to see what Carl's saying. That's next year's.
That is actually probably not problem, opportunity. But I think the way that we look at that is to remember that interoperability there provides a level of abstraction. That if you're able to access the shared health record directly using OpenMRS, it would be irrelevant data. You wouldn't have the demographics or that is all in the separate system. So to have a generic viewer could be done in a similar fashion to what we're doing, for example, with the technology service viewer, which is an HID app, which leverages off the messages that are already there. So with what Ryan's put together in the exchange contracts, the viewer that I understand the Ministry of Health is responsible for implementing for the hospitals in Uganda will leverage off those existing message specifications to get a record as they come to the hospital. There's nothing stopping us from stopping the project next year from having a virtual or a hosted OpenRISE point of care application which provides unlimited querying of the whole HIV but doesn't need to be deployed locally. So if you go to a specialist, they can go to mysharehealthrecord.nrs.gov.rw. Exactly. Yeah.
Their system is not yet separated or they haven't yet got the combination of the transparency I have interest as well.
And that is what the architecture is facilitating us doing. And when we look at the number of people querying the system that goes through the top today, there's very, very, very few people that get directly to the top registry services. So just to summarize what we were discussing now, the hospital viewer of the health record is a responsibility for the Ministry of Health to deliver, and we've got this interface towards it when we do not need extreme granularity in the shared health records.
Okay, then you said that our responsibility is drawn out by OpenMRS. So and I know OpenMRS has been designed to view the shared health record. So let's take the responsibilities again.
Viewer is an instance of OpenMRS is live and will be itemized.
But just to be very clear on doing that. Sorry?
In the ministry.
The ministry will roll that out. The functionality is the original work we already got in the point systems.
So just speaking for Roman, is it on the time frames that we think the project's going to need? I think we're working on a sort of large project and just put some quite aggressive time agencies on that. So we should just maybe check with mention that this is the sort of timeline.
I think we've been working on some functionality that the proper system is running and was the environment. But still we need to discuss because I don't know if with the current scope of working for stopping with the ANC. But if it's more than that, we may need to be discussing how what we can fit in.
It does sound to be that we need to have that discussion, be very clear about it, who's putting what together. It's very easy for us to say, well, you know, it's blowing it out and providing connectivity, but I want to come down to brass tacks as to who's putting the code together. That's what we need to be asking, what that is. So when the break session happens this afternoon, if we can ask Wayne, myself, Ms. Richard, myself, and Ron, just touch base about really talking about this as to who's responsible for what. So there's no miscommunication, any confusion.
Okay, so that answers most of the requirements clarification questions I have. Anything else?
I have a question. What is the scope? This comes back to Mead's point that he made earlier on his story. Everything for the patient or subsets of data? And those are clearly well defined.
We have a form for each one of them. Each data item is identified, mapped to current concept lab, work on each set of messaging or requirement. We know all the data that's going to be collected, one small section, and it's been improved.
Great. So we can add that for the summary to the developers.
And we're going to look at that tomorrow.
Yeah, they were going to look at it.
We've got a session to look.
Great.
Okay, so suppose that if I have any question related to
we had just a brief conversation with Derek Sorkin to step on for a second. But we suggest that we had a little working group, maybe some people that are together and review the authentication and authorization related to the OpenMRS instances in the facility. SHR, and where does it answer to this request? Is this first authorized to get this data as the answer, and how do we scope the information that is the answer? Because otherwise, every facility that is requesting to the agent, to the HX, anything will always get it, and that means that you have one unit in the classroom floating around and a lot of desktop machines that have independent access to all patient records. So, if you don't mind, let's try to schedule some time to do other working, just to propose an alternative, and then bring it back to the larger group for discussion and see if we can choose one that is pragmatic for us.
I agree, and actually by taking it out of the shared health record requirement, all we did is push it to somebody else, still have that issue.
Pushing it to the HIE is the right.
Yeah, no, we haven't decided where it's going to be pushing you to be role-based. It's not in the shared health record itself, it's got something.
I had a question that's maybe it's better answered in the discussions later, but I think there is a basic sort of foundational decision that I don't think we've fully made is in terms of what subset of information are we going to be storing in the shared health record. Is all of that stuff already in OpenMRS in terms of the class profile, for example, allergies, some of those key events? And to what extent is the shared health record a pointer to data in another system, an OpenMRS instance in a particular health system, as opposed to a complete replica of that? What's written into the specifications now, or is that something we have to decide this afternoon?
I can show you the stuff. So maybe a year ago, doing the field visits and everything, and meeting with Richard and other representatives from the Ministry of Health, we determined for the use case only that we're supporting now, the data that we would be pulling in. Just most of the antenatal form, the data from the antenatal form, there was an exercise to map that across the registries as well. And for the hospitalization and for the delivery, the only information that will be collected is a sort of internal summary. The date, time of delivery, mode, and so on. I can show you all the data and the forms and what we went to look here when we do the data mapping this afternoon. But for the initial use case we're supporting, that was the data that was identified.
I'm thinking that this is some of the discussions we have with a longer term view and perspective, though. So this obviously depends, in the short term on getting what we've committed to, but we would not want to set up a system that would expand to, at one point the Minister of Health actually said she didn't want anything selected, she wanted every record, every complete record from any EMR in the shared health record. And I think we successfully all became very quiet and by way of saying that won't work. But I don't think we've really explained that position. Maybe that's why, because she wanted to have everything in there.
Richard's been working on the structure to help formalize that.
Yeah, I know sometime back in the minutes I had the percentage to have all the information that is in the medical record to be published. But I think it was, she was saying that because she thought, she didn't trust some vital care in some of the facilities and so on and so forth. But I guess it's not such a data issue. And the exercise which is ongoing that we need to participate in the debate of the harmonized medical record should be addressing some of the things, because there is in the medical file, there is a detailed medical file and there should be a summary of the medical file. I don't know if you've talked about something like a summary of the medical file. So since this is being done by dealt with by the clinical science department. We shouldn't have so much to worry about. And from what I understand, the China Hospital can really take up quite significant blood tests, very small things like allergies and past diagnosis and past treatment only. And I don't feel it's a big concern anyway, as long as we respect the clinical sciences advice, which is local parameter, harmonized medical parameter, and about to complete, but the summary of it.
And that is what was correct, right? Okay, so
What Rich is referring to, though, is the same thing that Randy said. What happens next after NGO? And there is a broader project with the Ministry of Health and a structure that they put into place to assess things and say, out of the entire record, what are the important things, can we harmonize that across it? So we have everything for the use case we need to support, and beyond that, the plans and the infrastructure is getting in place for wanting to continue.
great. So that should be quite neat that falls into the next bucket.
Correct.
All right, fantastic.
Do we have that bucket somewhere?
Yeah, that's what I want to see. Every time somebody says next.
Yeah, I just wondered if somebody's capturing the bucket in her letters.
Right, and it's this question in a way is does OpenMRS have that capability to make to expand the size or the attributes of the shelter assembly in case you wanted to add more and more and more.
Yes.
Of course. Isn't that I think that's something quite
That's what's designed to do.
And one of the reasons why it's this complicated for the SHR is we don't need to call in any outside companies to do it. You have all the expertise you have in-house to be able to facilitate the expansion as it is.
But it's not been tested. I mean, I'm just going to be completely candid and clear with you. It's not been tested for the entire country shared health record. I think it will probably show pretty favorably once it is tested, but that's not something that we've done, and it's not what it's designed to do. So just be clear about that.
There would be items on the board. I think what shared health record is that if you want it, it just has to be copied through APIs. But as I said, APIs on the core so that we can forego some of the things that otherwise would slow it down because it's a
If you use the version I was alluding to there, yes.
Yeah, so that's it to the other final question I had, and that was around performance. I know there's a subtopic to some like root testing, that sort of thing, but that was way back in 2008. Paul, I don't know, sort of, do you have any facts and figures on the ANCAP implementation? That's one of the biggest ones.
Yeah, the implementation in ANCAP has close to 400,000 people in it.
We have a couple of implementations. ANCAP is 400,000, roughly 400 to 420,000. I don't know the exact number. And over 200 million clinical observations for those patients. And I know that there's an implementation in Haiti that has over 800,000 people in it with a very narrow set of clinical variables that are captured for them. And it's performed in daily function with upwards of 50 concurrent users in ANCAP. So I know that. But do I know, will it withstand the transactional burden, which I don't even understand what the size will be. So it's really hard to kind of speak specifically to it. I think the only way that you properly assess whether it can withstand the entire country's burden is to actually create some semblance of what that transactional burden will be and actually do the test directly in this environment. I think that's the right way to do that. I don't think that you want to rely upon the suppositions of people that have done something not with the intention of looking at it as a shared health record. But as a community, and that's the whole point of it, so that people can jump in and start testing it against some of the use cases. And we would encourage and support that, obviously. But I've been not quiet in this, hopefully that should feel inherently biased. So I want to just be clear that, you should go to the community for this stuff, and they talk to people that can ask about this. There's a road mapping process where if one is saying they want to use it as a shared health record, and they want the community to explore extending the functionality, doing testing and that sort of thing, there's a process to allow that to happen. And so that's where Rwanda should take advantage of that the same way everyone else does and say, yeah, we want to use it as a shared health record at least for the next year while we're considering alternatives or whether we should stay with it. And I think there is a community process that allows that to happen, I think.
Yeah, that's something you want to try.
And then you can ask, Sharon, can you share with us your experience on the PIS sites? Because I know that how many? 24 sites, and you do see that there's a huge amount of the 24 sites. Maybe that will also serve as another case study of practices.
Okay, so we use synchronization for two different things, and I'm not the technical person to explain how it does this, but we, for years now, we've used it to sync the data between the sites. And at the moment, the way the synchronization module works is that it syncs all of the data, but there's interest in actually specifying how to change synchronization modules so that you can say, only send this, or only send it to this place. But that doesn't exist yet. The other thing we use Sync for is to actually sync content like forms, new modules. We're finding so many sites it's really difficult to get the content out, particularly because 18 of our sites use MTN modems to synchronize data, so we're working over slow connections. So either you're sending people to 24 places, you're sending your developers there, or we're bringing everything in all the time. So this is something that Dave Thomas had worked on, and I don't really know how it works, and I can refer you to the people who can. But we're now using that to push content out, and the release we just did 2 weeks ago was the first time that we had, actually the second time that we released that. So I think that I can connect you with our team to discuss those options. I don't think we would recommend jumping into doing full data syncing. It's still being debugged in some ways, and I just don't think it's a good idea yet, but I think that the RSync might be something to consider.
How many patients?
How many patients? So we have 2 separate databases, and we have probably 25 to 30,000 in our Eastern Province database, and we have about 3,000 in our Northern one.
But you wouldn't know the number of the counties.
No, I wouldn't. I mean, some of them are HIV patients that we've had since 2005, and others are our primary care registration visits. So I couldn't tell you that off the top of my head.
Okay, so step back to it, and we will obviously, as always, continue this evaluation, look into that in the coming weeks. But I do also think that we still need to evaluate alternate options as well. But at the same time, having said that, we have a very small window in which to identify a solution and get something to ground. And so, my question to the group is, from your experience, are there other good alternatives that we should consider? And what strategy should we use to rapidly evaluate it?
Derek, given your background in CHP, you might have some insight here on this.
There was kind of my recollection was the ones that we looked at, and it was kind of like we prototyped any of those SHRs. The one that we had installed when the Mohawk had themselves, they didn't rank as high as Antelope. It didn't rank as high as OpenMRS did, so I actually feel pretty comfortable with this decision. I'm not sure what we'll gain by continuing with other evaluations. The SHRs that I know of and I'm familiar with are great. Will certainly handle the load, but also very expensive. The commercial products that show up in Connect the Funds that we see at the EHEALTH conference every year for millions of dollars. And I don't think that's something that to do with the universal course.
Talk a little bit about, and just reiterating, I think, some comments from yesterday about how when you have standard messaging to and from components, so that inherently allows us to be able to take if for whatever reason they want to evolve new technology, they can do that in a way that applies equally in this case.
It does. And one of the things that I can tell you is in production, it's rare to continue to use the kind of messaging that you use to the outside world between your HIE, or you can't really call them HILE, but between your HIE and the SHR. You typically want to use a native messaging bus when it's made available. That's why I asked if we've got native API to the core. That's probably the one that will go fastest. Otherwise, you have to marshal an HL7 message on the calling side. You'll have to unmarshal it on the receiving side. And the truth is, everything above the HIE is rolling lights to be really, really fast, because that's where the traffic levels are, like banking network traffic levels. It's a lot of traffic out there. So the truth is, although it would open up other opportunities to say, oh, I'm using HL7 V2 message because I know there is one, it would just slow down everything. And I think we'd be better off to say, I use some native messages because they're available to me. That's probably the same decision we make if we dropped in anything else. I mean, typically some of these applications that are used for shared health records are things like work-related or whatever, use data, all this. It was OpenMRS was the number one ranked one out of the CHP project. I think everybody should take some comfort in that.
I think the other advantage perhaps is that what Liz had mentioned earlier, we wouldn't have to design an elder interface, a web interface to the data or something like that. So presumably you could also synchronize the forms so that if you had a history of an antenatal care visit, you'd use the same form on that centralized system to view it.
Actually, really, we made a decision not to let anybody look at the shared health record from the public area. You have to put it into a point of care system, albeit very thin. We don't want people directly interacting with the shared health record because there's a lot of registries one has to touch on that side. So just to put that point in there, that would be something just put out.
Is there still a requirement for the shared health record to support any standard like that ISO 13606 or AHR? Or is that just an implementation specific? Or we still want to do that?
So I thought that was specific to the solution we're evaluating at that point. I don't think that's part of it.
I think we really need to look down at what advantages that give us if we read that way versus the expense that it will cost in terms of getting things up and running and pushing forward. Particularly, I keep coming back to this concept of who's going to support it. That's a very, very big question to be asked. We put a system down that has no prior experience in Rwanda. How are we going to be able to ensure that we're able to move forward and continue being used? The fact that OpenRun has a big footprint and it has ranked so high on one of the top ones of the CHP project, it may not have been originally designed to fulfill this exact role, but the data model underneath it is designed to be as generic as we want it to be. And within this room, if we ask anybody who's ever touched OpenMRS or worked with OpenMRS to raise their hand, I've been a chocolate cake with about 75% of us who actually understand what we're talking about. And that goes a long way to allowing us to put something down and make sure it works. And to quote Derek from yesterday, again, we just don't have to make the wrong decision. What we use for the shared health record, we can switch out at a later stage in year 2, when it's going too slow or it's not meeting the expectations we have. But off the top of it, or our gut feel, we should use it when we last yesterday. It is a strong match, and it's a system worth evaluating, putting down, and moving forward as best we can.
We also, sorry, I didn't agree that the architecture doesn't allow you to swap out components, but in terms of the process going forward, are we making the decision now to focus solely on OpenMRS?
Well, I don't think we have the time to do anything else. Unless somebody disagrees with me or can give us an alternative that we can start evaluating as of today. All the searching that we've done and I've done, there aren't really many other systems that give us what we need at the moment. I'm looking to the expert Derek.
There are a lot of alternatives out there. And I can tell you and I've seen a lot of them implemented. I can tell you that I don't think that there's anything that that is going to be a bigger win for us, all in, than OpenMRS would be. So I can't see why, given the products that I've seen implemented, I don't mean just in North America, I mean like all over. I don't see any one of those that is such a head and shoulders advantage that we should spend the time. This really is a decision that isn't the wrong one. And I'll caution that with one of the things that we don't know, and we're going to go through the process of stressing some of the other applications that we're looking at. I would tell the room that one of the things that we should look to as a failure mechanism that has brought Oracle to its knees on occasion is, can it handle the kind of traffic that it's going to see above that HIE? And we can find that out very readily, and then take whatever measures we need to take between now and the start of the phase 1 to make sure that we mitigate that, and then let the community chew for a year on what it's going to need to do to handle the next kind of traffic level it's going to see when we get out of our phase 1 and into our countrywide phase. But that will be the key. The data model issue, I think, is a red herring. If it wasn't a sufficient data model, then it wouldn't be able to handle all the patients it is caring for.
I agree. I think the stress testing algorithms start to scale from our implementation to national is going to be crucial to identify, do we take it forward and add resources to ensure that MRS can evolve to match that, or do we look at alternative solutions? And each of those gives you an opportunity to really evaluate the requirements that were gathered in this project and be sure that if you do look for a commercial system, everything has to be tested.
I would also hold out that if we don't find that it can handle the load, that will force us into the arms of looking for others, because on occasion, and this is even with commercial products that cost millions of dollars, sometimes it's an architectural reason why it can't handle the load. I actually don't fear that right now, but that's a possibility. So, that should be the first thing we do is stress this. Because that's, in my view, that's the only thing I can see right now that would force us into the arms of having to find some alternatives.
All right.
Yeah, so that's a commercial the decisions and clarification that.
I mean, the only thing I can say with confidence is that from what I understand from this district and what you're looking to do, we'll have no problem handling that. Because it already has implementations that hinder a much higher volume of that without any problem. I just don't know what it needs to be a countrywide implementation.
Concurrent code.
I have no idea what the transactional burden capacity actually is. We don't even have the estimates for that yet, so I can't really say yes, it will work. I don't think the community is testing it quite that way yet, so that's helpful.
That's a question or a request or comment from Paul and Sean. I know you have the commercial exchange and shared answer back home. So, and this, I suppose, I'm reviewing over time. So, your personal opinion, when you compare that to OpenMRS, do you see OpenMRS moving into something like nation? I'm sure not much happens from us. I don't know if it's a commercial product or something that's reviewed yourselves.
So, yes, one of my first responses to that is OpenMRS is based on that system that we run on. So in terms of the data model and the capability to accommodate that sort of information, it absolutely, it's sort of the next generation. Now, also, hasn't tested at scale yet, and everything needs to be, smoke testing, absolutely. But it's, OpenMRS is derived from that system.
Which has, how large?
Yeah, and that system has now 4 billion discrete coded results, going on to 5 billion with over 25 million unique patient registrations in it now.
Now this model.
Yeah. So it certainly has good lineage, good genes. But like every child, we need to test it.
We're not going to do a sales chapter.
Yeah. I can say I'm optimistic, but
to Sean Taylor, today. I want to come down to some action points, which are you happy with that decision? What we said today is, inspiring confidence we can move forward with open MRS. All right, so we can move that together and Wayne, go. Because I think this will probably bring us into the conversation around the messaging needed on the train. Would you like to that one?
Sure.
And in fact, we're back on lunch. Let's just check if lunch is ready for you to take the messages.